Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Primary care is the term used for health services that cover prevention, wellness, and treatment for common illnesses. It is the foundation of any health system. Your first stop for care, the first point of contact. Comprehensive and coordinated primary care is associated with better health outcomes. But primary care faces massive challenges globally. Uneven access to care, workforce shortages, increasingly complex health and social issues, clinicians just generally feeling stretched thin. And if on top of that you layer on disability or chronic medical conditions or poverty, that's a lot to manage, especially with limited resources. Primary care is what should keep people healthy and out of the hospital, but delivering it consistently, that's incredibly difficult. And that difficulty level, it just seems to crank up dramatically the further you get away from big cities. Today's episode of Mapping Healthcare is about how primary care gets delivered in geographically isolated communities and what its unique realities are on the ground. This is where our standard models of healthcare delivery get tested the most. The context here isn't just a bit different, it fundamentally changes how care has to occur. Let's visualize a place like this in a remote geographic area. We're talking pretty isolated. A small community with a few hundred or at the most a couple of thousand people. And in this kind of setting, they may or may not have a medical clinic. And there's definitely not a hospital. Which makes me think about the people on the front lines. Physicians are incredibly hard to recruit there. In Australia, for example, you have remote area nurses who work in these areas. The scope of practice of these clinicians is incredibly broad. They essentially need expertise across everything. Emergency care, acute conditions, maternity, child health, palliative care, prevention, screening, chronic disease management, definitely far beyond what might be needed in many specialized urban nursing roles. Healthcare in remote and rural communities relies heavily on the dedication and extraordinary adaptability of clinicians working there. They basically have to be ready for almost anything that walks through the door or that they get called to handle. They need to know what's happening for people outside the clinic in their lives. Understanding a person's social context, their support network, their living situations, it's all vital for providing effective care in these often close-knit communities. These clinicians also face limitations of resources, not enough equipment, not enough supplies, or sometimes simply not enough time in the day to do everything they feel they should. They're constantly navigating resource constraints, and this sometimes means difficult compromises in care delivery as they work hard to meet complex patient needs. So they're delivering absolutely essential services under immense pressure. Communication challenges can also be an issue, particularly when working with communities where English isn't the primary language. That's quite a challenge, trying to provide complex care across language barriers with limited support and resources. A significant chunk of people in these settings travel quite far to urban communities to get care. So you have all these conditions, workforce issues, complex patient needs, access barriers, transportation needs. So what kind of solutions do we have? One solution is telehealth or virtual care. It's a natural fit for remote areas. Bridging the distance makes it easier to connect with clinicians without traveling long distances. The Australian Bureau of Statistics classifies geographic areas into 5 levels of remoteness based on their access to services. These 5 levels are major cities, inner regional, outer regional, remote, and very remote. The Tiwi Islands in Australia's Northern Territory fall under the 5th level, very remote Australia. Our guest in today's episode of Mapping Healthcare is Dr. Tim Shaw. We talk about how the Indigenous community on the Tiwi Islands is working hard to bridge this gap using technology to make sure that their residents get the primary care that they need. The views expressed on the show are mine and those of my guests. So Tim, welcome to the show. You are a professor of digital health and director of the Research in Implementation Science and eHealth group at the University of Sydney. Implementation science is the study of how to best get research findings and evidence-based practices into routine use in healthcare and public health settings. So tell us briefly about some of the work you're involved in as part of that role.
I work in a wide range of projects across Australia and some internationally with a focus on, as you mentioned, implementation science and digital transformation. I also teach as an academic, so I also prepare the next generation of health professionals so that they can actually operate in the new world of digital health when they graduate. I guess my key focus, though, is really that nexus between how we get research into practice and what does that mean? So how do we bring research right alongside and embed it within practice? And most of my research is really focused around how we develop strong partnerships with government, industry and services to do that.
And Tim, your research focuses specifically on how digital health can support new models of care and how health data can support improvement. And today we're talking about some work you've been involved in to support primary healthcare in remote communities in the Northern Territory of Australia. The goal of this work is to understand how technology can improve comprehensive primary care in remote Indigenous communities. And primary care generally is a term that's used for health services that cover prevention, wellness, and treatment for common illnesses. So tell us what some of the health challenges faced by people living in remote areas in the Northern Territory of Australia are.
As with most or many First Nations populations around the world, there's a significant gap in almost every health metric between First Nations and non-First Nations population. And it's certainly the case in Australia. We're obviously a first world country with some of the best health outcomes in the world, actually. But our First Nations people suffer from many issues of health. Obviously, there's high levels of chronic disease. It's one of the primary areas. Mental health issues are a significant concern. Smoking rates are higher. There's all of those issues kind of surround First Nations people in Australia. But I must say right from the start, from the work I'm doing, we try and focus more on the strengths of the population rather than just deficits of that population and try and understand what that is. And, in the work I've done, I've started to really understand what intergenerational trauma means and really what are some of those impacts of why are we getting young people with, significant heart disease when they shouldn't have it. And so I think all of the metrics we have show that our First Nations people on the whole have lower health outcomes than other people across almost every metric.
And the project is really impressive. It's a partnership between many groups. Among them are the University of Sydney, then you have the Northern Territory Health Group, the Australian Government Department of Health, and then you have the Northern Territory Primary Healthcare Network. So the focus is on working closely with First Nations communities in the Northern Territory and with Indigenous providers there to develop community-centered care models. And telehealth is widely used in remote communities across many countries, but there's a real gap, as you mentioned, in understanding how the local population, in this case, Indigenous Australians in remote communities like the Tiwi Islands, a place where you work in, want to use digital technologies to support their health and their wellness. And these many project partners that you work with and you spent quite a bit of time learning about and prioritizing community viewpoints. So what are some of your key takeaways from your research when you went in and spoke to communities that you work with?
We very purposefully brought that team of partners together, and we have senior representation at each of those partners where people can actually make decisions to change policy and practice. And they see this project as a project that they can have access to, because it's very hard for them to access these communities, so they can actually see what's going on, understand that and change policy. So there's a direct pipeline there. I think in terms of what we're learning, as you mentioned, one of our key focuses around what do Aboriginal and Torres Strait Islander communities actually want from technology and how will that be used, as well as actually mapping how technology is currently being used. So I think the number one thing is that communities want technology to be culturally appropriate. We did a survey of over 50 community members in the Tiwi Islands, and that was the number one thing. So how do we make that culturally appropriate? And to understand that, if you unpack that slightly, that's really about ensuring that the way that we deliver that healthcare fits in with the cultural priorities and how people actually operate within a community. So it doesn't work if you schedule all your telehealth consultations for 8 o'clock in the morning on a Monday, and you don't accommodate for sorry business and other things that happen in community. So you've really got to start to understand and build the way that we deliver that care in to fit with the community norms and preferences. And that's something that we really don't do at the moment. I think some of the other key take-home messages were that many people in community use technology now. There's a lot of paternalism and assumption that First Nations community members don't have technology or don't have users. That's just not the case. There's a reasonably wide penetration of technology in. Obviously, in our remote community, we still have a deficit around bandwidth and access. People don't always have the funding to maintain a plan to access phone and internet, although that is gradually getting better. And that's one of the outputs of this project as well, to look at that. Clearly, when you're remote communities, one of the priorities is, well, people don't want to travel, or they want to have the choice. So to go from Tiwi Island to Darwin, where the hospital is, it's only an hour-long journey on a small aeroplane, 7 to 9 seat flight. But that can take 4 days for somebody that leaves community, just go for a 15-minute consultation. By the time they've got to the Darwin, met with the clinician, they're not allowed to book their flight back until they've seen the doctor. They have to live in a hostel with people they may not be familiar with during that period of time. So it usually takes about 2 to 3 to 4 days to actually have that encounter. So, and the strength of a community is to stay in community. So every time you remove somebody from community, it puts them potentially at risk as well within the larger cities. So I think one of the key things is reduce that travel, but still give people the choice to go to see somebody face to face, just like everybody else would want from time to time. I think other things we've learned as well is that people use technology in community, but they don't tend to use it for health information. So one of our projects is how we can use technology to increase that access and empower community to understand that. And when you look at health information, it has to actually be relevant to community. And just making some of your characters on your website brown does not constitute making information culturally appropriate. It's actually understanding how you relate that and how do you actually make health information relevant and interesting and engaging to Aboriginal and Torres Islanders within community.
Tim, when you and I first spoke about your work in the Tiwi Islands, I looked it up on the map, and the Tiwi Islands are located in Australia's Northern Territory, and they're a small group of islands that includes 2 larger islands, Melville Island and Bathurst Island, as well as 9 smaller uninhabited islands. And I read that Tiwi literally means 2 islands. And they're located, as you mentioned, about 50 miles north of Darwin, Australia, and they're home to about 2,500 people, the majority of whom are Tiwi First Nation people who maintain their cultural and their linguistic identity, which is really key when you go in and try and implement interventions as a scientist. So what are some of the programs and innovations that were implemented in this community because of the digital health work of this team?
So within Tiwi Islands, one of the first things we did was to actually really explore why the connectivity was poor within the health services, because it wasn't working for telehealth capability. So we worked closely with the NT Health to actually open up telehealth as an option within that, because it just wasn't there. The community was telling us that they wanted choice in who they spoke to and how they interacted with health professionals. So we opened up a telehealth facility within the Women's Centre so that community members, women, could go to the Women's Centre in a safe environment and talk with a known general practitioner in Darwin and have that interaction in that safe space. That certainly was well received. It also opened up all the challenges we understood about how do you schedule that, how do you manage that, how do you actually put the resources around this to ensure that outside of a clinic, you actually have the ability to manage that. So that's some of the research we've been doing around that. Within Tiwi, we've also established an SMS program. SMS is a fairly low bar entry point for people in terms of technology. You've just got to have a mobile phone. So we've just been piloting at the moment about to roll out a larger program of health messaging written in collaboration with our Tiwi colleagues, both health professionals and the community, taking a very strength-based approach to send health messaging to community members, to help them, remind them to go and have health checks, to keep their culture and their family strong, and what can they do with that, and then linking that through to making sure that they go hunting, fishing, those types of activities that actually are really culturally strong for them, and they go there. Also, how they play football. Football's a really important thing on the Tiwi Islands. In fact, a number of Australia's best footballers have come from Tiwi. So it's to encourage people to do sport and exercise and so on. But we've crafted that in partnership. And as well as individual initiatives, really what we've done is map how technologies are being used across the territory. And what we found is that most of the telehealth interventions are still really kind of quite individually driven. They're individually driven by a general practitioner that wants to use technology, or a specialist within Darwin. And we're just seeing the emergence of what we're calling much more hybrid integrated models of care, where you actually understand what the desires of the community are, what the health requirements are, and then you actually design the model of care around that. Because it's always dangerous when you just talk about telehealth as a standalone, as a swap-out methodology. It's a useful tool, but it has to be embedded in a broader redesign of the model of care you're trying to deliver. And so what we've been doing is mapping those processes, identifying areas where there clearly are redesigned models of care. And we found one of those in how cardiac care is managed in the Northern Territory, where they have a hybrid mix of face-to-face, fly-out visits, and then retrievals for people that need that back into Darwin. But it's a well-organised program. So it's not just one-off telehealth when you need it. It's actually about managing the healthcare of that population in Tiwi and making sure people don't fall through the cracks.
Yeah, and I really appreciate your thoughtful approach to designing for implementation and sustainability. As you know, the success rate of digital innovations has quite a bit of variation. And we know from the literature that about 70% of digital innovation projects fail to deliver their intended benefits. And the uptake of digital innovations is not just about connectivity or technology, as you described. So tell us what workforce level interventions are needed to support the uptake of such digital health innovations.
As always, the technology is the easy part. I don't want to underestimate the really significant challenge that we have of such a vast nation and such remote communities, but particularly with things like Starlink coming in, where now we've really got high-speed broadband that's affordable. And so I think the technologies can be fixed. So then I think, as I mentioned then, it's more about the redesign, and workforce is pivotal on this. As in the majority of remote communities internationally, workforce is always a challenge, and you can't hire our way out of this. It's really, really hard to hire people to go work in communities. You have a high turnover of staff. Some communities might have a GP, others might not. And so you've got this constant churn and turnover. So that makes it especially challenging to get interventions in, which is why we're encouraging government to look at systematic approaches to implementation of these activities, looking at ways that you can use technology to maintain workforce. So we have multiple instances we've observed of young clinicians that go and work in a community for a number of years. They might have children, they may need to go back for family concerns, and they leave the community, they're lost to care. But we're seeing some of the more progressive communities then start to actually re-employ those people as telehealth consultations. So they're known to community. They may be living 1,000 kilometres away, but they're actually integrated into the care that's delivered within the community. Therefore, you're maintaining that strong link. They can mentor face-to-face new clinicians within the community. They often might fly up and do a month a year anyway within their own, and they enjoy that a lot. But then you're kind of redesigning that care as well. So then you're actually employing somebody under a different set of conditions to provide that service. So you maintain the workforce and you can then help grow that workforce.
Yeah, so lots of challenges and lots of things to think about, but your team has gone about this in a really creative way. And a really key part of your work is that it integrates co-production and co-design with the local community, collaboration between people in the community, researchers and policymakers, decision makers, helps drive efforts to solve complex health problems. And your team has shown us a really excellent way to do that. The meaningful involvement of community members is really essential, as you know, to make sure that changes we make are designed, implemented, and evaluated in a sensible way, in a way that works for the community. So embedding Indigenous researchers in teams like yours helps ensure that once the researchers have gone away, that the model has impact, it's scalable, it's sustainable. So really important work that other groups can learn from and can replicate. Your work really engages Indigenous researchers and health practitioners in a really meaningful way. So tell us about your collaboration with the local community you work with.
Yeah, this has been absolutely vital. And I can't take credit for the design of this. I hadn't worked in remote communities up until 4 years ago, and I've worked with some very experienced researchers in Alice Springs and Darwin. There's a couple of things they emphasize that, go deep in a small number of communities rather than going shallow in multiple communities. I mean, sometimes you have to do that, but it's much better to actually spend time in community because it's all about trust. Then the other thing that we've done, as you mentioned, is we've actually employed community researchers. So employment's a key challenge for communities. So you're making a couple of impacts there that you're actually giving back to the community immediately. And we really emphasize that. And that has to be at the core of all the research we do. You can't just say you're coming in and you're going to research them. They're some of the most researched people in the world. You actually have to give back to community straight away, both from the outputs of your research, and employment's another key thing. It's been enormously rewarding to employ two community-based researchers, and it just gives us the total understanding of what community is. I speak to them regularly. We speak to them weekly. Whenever we're going into community, it allows us to understand, is it appropriate to be going in? Is the sorry business going on? How do we handle that? And they become friends and colleagues. And it's been a very different way of working. And it's so different from kind of clipboard research, which they so often see, where a plane lands, people leap out with clipboards, run around the community asking everybody questions, and then jump in the airplane and leave on the same day. Whereas I've actually learned that the weekends are probably the most important time to be in communities. You sit around and you talk, and you might go fishing, you might do things like that, but that's what actually builds the trust. And sometimes I think that's more important than anything we've actually done.
I learned this along the way as I was researching for this episode, but you used the term sorry business, and that's a term used in Australia's First Nation cultures. And you can correct me if I'm wrong, but my understanding is that it refers to a period of mourning and grief, and particularly surrounding death in the family or a loss, right?
And in fact, I've just reflected myself, and I recently lost my mother, and we don't have a word for this in non-Indigenous communities. We have mourning and things like that, but we kind of battle through and carry on. But in communities, they have a much more structured approach where they do genuinely come together and they stop what they're doing and they focus on that sorry business. And that's different for each culture and each community, but it's really important. And that's one of the key areas you have to respect in terms of healthcare delivery, as well as the kind of research you're trying to achieve. I think we can actually learn an awful lot from that personally.
Yep, well said, Tim. And I can clearly see that this work must have taught you a lot about how best to hardwire changes in a community. For example, you mentioned that you used a strength-based approach and spent a lot of time with remote Northern Territory communities learning about their strengths. So tell us how this project changed you as an implementation scientist, your own approach to your future research.
It's changed on lots of levels. I mean, one, I find it so rewarding working in communities such as this, and the gap we have in Australia and in other countries with our First Nations. Health is a massive stain on everything we do, and we need to do this more. So it's really emphasized that for me. We're just meeting young men that have had a heart attack in their 30s and terrible suicide rates we have in these kind of things. To me, it's just reinforcing that sometimes we need to emphasize and focus where we do our research. I think, as I mentioned before, it's made me understand, how to step back in this type of research and not be the leader, and support my Indigenous colleagues and First Nations colleagues to actually lead that work. And how do we actually do that?
So, Tim, as part of your work, you travel to the Tiwi Islands, and these islands are really remote. And to get there, one needs to take a ferry, or as you mentioned, a small airplane from Darwin, which is the capital of Australia's Northern Territory. So you've hitched rides with the Royal Flying Doctor Service to get to Tiwi Islands, I understand. And so tell us a little bit about that experience. Are you a nervous flyer? How did that go?
First time I went in, I flew with the Royal Flying Doctor. It's a lot of fun, right? I'm actually not a nervous flyer. I really enjoy it. It's great fun. Since then, I fly on just the regular commercial flights, but they're tiny. They're 7 to 9 seaters, sometimes take a 4-seater plane. And look, this is one of the health challenges, right? You have to clamber up a little ladder, jump in the plane, huddle yourself down to the front to get in your seat. You can imagine somebody that's got chronic disease management issues and things. It's very hard to do that. I think the other thing is that, flying in the wet season half the year in Darwin, it's massive thunderstorms. And Tiwi Island actually has one of the most stable thunderclouds in the world. It's called Hector. It has a name. It was used for navigation in the old days. And when you're in a small aircraft flying through thunderstorms, it's really quite exciting. And I do have a couple of staff who are nervous flyers, and it's certainly been a baptism of fire for them to fly into community during the thunderstorms. But it does actually really emphasize that some of those challenges of how you get in and out of a community.
Yeah, exciting, scary, fine line between those two experiences for sure. And so in the show, we talk not only about the topic that we're focusing on, but also a little bit about the place that our guest on the episode works in or comes from. So talking a little bit more about the Tiwi Islands, a permit is usually required to travel there. However, I read that for 1 day a year, Australian rules football lets people access to the Tiwi Islands on grand final day, and that's in March every year usually, to experience the passion and the excitement of Tiwi football or footy, or as they say, soccer in the US. So for people lucky enough to visit, what else do you recommend they check out in addition to the football?
They're stunningly beautiful. And there's just a peace that I can't quite describe in the Tiwi Islands, the silence and no aeroplanes, few cars, just a little, turboprops coming in to the airstrip. So they're stunningly beautiful. There's some fabulous fishing around the islands, and I've been lucky enough to be taken up to some of the homelands of the people I've got to know, and I've been fishing with them. There's amazing artwork. There's some very famous artists that come from Tiwi. You can actually catch the ferry to Waramianga any day of the year, where you can get a temporary permit to go to the art centre there, and that's beautiful. So certainly highly recommend that.
Thank you, Tim, for sharing a little bit with us about this beautiful, unique piece of paradise that you've had the privilege to experience. And those are all the questions I have for you today, Tim. Thank you for joining us on Mapping Healthcare, and have a great rest of the day.
Thanks, Fact.
So that was Dr. Tim Shaw telling us about the sea change that technology can make to primary care for communities in Australia's remote Tiwi Islands. You heard about why this work needs to be designed with the local community to make sure that health innovations work well for local contexts and cultures. The physical distance to travel for healthcare, it impacts everything, including the workforce. In the US, there are far fewer physicians in non-metropolitan areas. We're talking roughly 3 primary care doctors for every 10,000 people compared to 8 per 10,000 people in metropolitan areas, and far fewer specialists. So that places a significant burden on primary care physicians, nurse practitioners, physician assistants, and nurses to take care of people there. Providing primary care in remote areas paints a picture of incredible human effort and ingenuity, constantly trying to overcome geographic and resource limitations, using humans and technology to make it work. And when it does, it's quite remarkable to see how it makes a profound difference on the well-being of people who live there. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. All this talk about bridging geographic distances reminds me, I'd love to hear from you. Please connect with me on Instagram at Mapping Healthcare to share your thoughts and your ideas for future episodes. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts. If you enjoyed the show, please don't forget to subscribe and leave a review.